Well, good evening, everyone, and welcome to session 3 of the Diversity and Inclusion webinar series, Minorities in Medicine, a look at physician diversity. This series is a collaborative effort of the Bay Area Medical Societies. A shortage of underrepresented minorities in medicine has origin from several determining factors. This presentation will review the past and current hurdles affecting this group of potential students, residents, and faculty for medical school, the current environment and efforts by some areas of medicine that are actively recruiting at all levels for their specialty. My name is Dr. Cliff Wang, and I will be moderating this session. I am chair of the Department of Medicine at Santa Clara Valley Medical Center, clinical associate professor affiliate at Stanford University, and clinical associate professor at Geisel School of Medicine at Dartmouth. And I've been working on our enterprise committee on health equity and racial justice at 3 of our institutions. I want to give a shout out to Dr. Sophia Mahari and Dr. Abby Pitts, who have led this charge to end systemic racism in our system. I'm currently president-elect of the Santa Clara County Medical Association, and I want to especially thank Dr. Randall Pham, Vice Chair of the Ethnic Medical Organization section of the California Medical Association and Vice President of Member Services at the SCCMA, for inviting our speaker tonight, Dr. Keith Carter. I look forward to hearing some of your thoughts, Dr. Pham, at the end of this presentation. It's my honor to introduce tonight's distinguished speaker, Dr. Keith Carter. Dr. Carter is the Lillian C. O'Brien and Dr. C.S. O'Brien Chair in Ophthalmology and Professor of Ophthalmology and Visual Sciences and Otolaryngology at the University of Iowa Carver College of Medicine. He is past president of the American Academy of Ophthalmology and past president of the Association of University Professors of Ophthalmology. Dr. Carter earned a Bachelor of Science degree in pharmacy from Purdue University and a medical degree from Indiana University. He completed his ophthalmology residency at the University of Michigan and a fellowship in oculoplastic and orbital surgery at the University of Iowa Hospital and Clinics. He's been on faculty at the Carver College of Medicine since 1988. In this capacity, he has served as residency program director for 14 years and was appointed chairman of the Department of Ophthalmology and Visual Science in January 2006. He is a board certified by the American Board of Ophthalmology and is a fellow of the American Society of Ophthalmic, Plastic, and Reconstructive Surgery and the American College of Surgeons. He has trained over 150 residents and 20 oculoplastic fellows. Dr. Carter specializes in oculoplastic surgery and has conducted an extremely busy clinical and surgical practice for the past 30 years. In July 2020 of this year, Dr. Carter was a participant in OWL, the Ophthalmic World Leaders virtual program, instigating change and honest discussion on race in ophthalmology. He currently serves as the chair of the AAO-AUPO Minority Ophthalmology Mentoring Program. He has been actively involved in diversity and inclusion committees at his home institution. Before we start, just a reminder, please type your questions in the Q&A box. And if you'd like to speak, please click on the raise hand button and we will unmute you. We have provided a copy of the presentation slides for you to download in the chat box. Without further ado, please give a warm welcome to Dr. Carter.
Thank you. Okay. Good evening, everyone. It's my pleasure to join you tonight to talk about minorities in medicine, a look at the physician diversity. Okay. So diversity, equity, and inclusion, the biggest challenge we have is to recognize the need for action. We talked about this for years. It's interesting, the foothold that is taken today, which makes me very happy. It seems like young people are seriously talking about changing and being more fair in our society, and that's good because diversity brings value. But the journey continues to be a long one, and who knows how long the traction we'll have that we see today, how long will it last? Because society changes very slowly. You cannot expect society to change quick. Normally what society does, it overreacts, and then the needle drifts back to the center. And when it comes to race, it seems like we haven't overreacted yet. So I'm not quite sure all the change we hope to occur is going to happen, but I'm hopeful. And in your neighborhoods, your organizations, your companies, and your university will all benefit from diversity. Now, the world of golf didn't do too bad when this guy showed up. And I think he made a lot of people a lot of money, and he popularized golf around the world. And despite your political affiliation, this guy didn't do too bad either. He got 2 terms in office, and he really came out of nowhere, where as my mother would tell me, she would never think a man of color would be in the White House, and it happened in her lifetime. And if you look at the House in the 2018 election, you look at the diversity of the members of the House, and it shows you how our country's population is changing and why diversity is going to be even more important in medicine as we go forward. One of the things that holds a lot of us back are our own implicit biases. These are real. They're attitudes, stereotypes, and mental shortcuts that affect our understanding, actions, and decisions in an unconscious manner. We all have them. This is not specific to any racial group. We all have them. And we have to make sure when we interface with people that we recognize our biases. And sometimes I recommend you take tests to sort of show you your biases. And oftentimes it's nice to verbalize your biases so you recognize and make adjustments to them. This, I think, was
news tonight about women in the workplace.
This is about women.
This woman became CEO of a big auto company. The hard fact is that women run only 4% of companies in the Fortune 500, and a new study shows almost twice as many women as men say they've been turned down for a job because of their sex. So is there a way to capture what's happening on tape? Looking at 2 people in a job interview, the only difference, their gender? Well, here's ABC's Cecilia Vega.
He's the boss. She's bossy. The negative way women are perceived at the office in a new ad for Pantene that's gone viral. It's hit a nerve, so we set out to find the truth. Are women who act exactly the same as men seen differently? Listen to this woman. How do you feel about her as a job candidate?
I know the Windows operating systems like the back of my hand, no problem.
Now, listen to him.
I know the Windows operating systems like the back of my hand, no problem.
The candidates in these videos are actors in a Yale University hiring experiment. The resumes, identical. The interviews, identical.
I'm extremely good at
sizing up people quickly and delegating responsibility accordingly.
The only difference is gender. But when it comes to who got the job,
I thought the male applicant had better soft skills. Say the woman was arrogant and overselling.
In hundreds of evaluations, the female job seekers come off as more aggressive, are rated less likable, and they're less likely to be hired.
Isn't it a catch-22? You're supposed to be strong to get that job, and you're saying if you're too strong, you won't get it.
You need to behave in this dominant way to advance as a woman in the workplace. But you're seen negatively because that's not how we expect women to behave.
And if you think this is just male bias, it's not. Both men and women doing the hiring made the same call.
I think there's a level of arrogance that might be okay to be a manager, but then there's a step above, and I thought she was something about that.
So let's talk.
And when we revealed our study results,
I was surprised by my reaction.
What does that say about us? We have a long way to go.
a science experiment with real-life lessons about who gets the job, who gets passed over, and why. Cecilia Vega, ABC News, New Haven, Connecticut.
News tonight about women.
I think that's what the lady said, we have a long way to go, is very relevant today. I mean, I've sat on search committees, and it's true. Sometimes the people you're supposed to be advocating for are the people that you're the hardest on. And that's really from our inherent biases that you sort of pick up through the media, through TV, in your own life experiences, and you really need to recognize them to move forward. As we know, minorities in healthcare have been lagging the percent they represent in the national census for the past 30 years. We know that. The healthcare challenges are being seen today with COVID. The disparities in healthcare has been exacerbated by COVID. Minority groups are being affected most by COVID because the healthcare system is not as good. We need to be doing what's best for our patients, and our patient populations are changing, and that's very important as we make this argument for diversifying the field. For example, language, huge impact is to know the patient's language. I've had experiences with interpreters, I'm quite sure all of you have, and you sit and you say something and you put 4 sentences together and the interpreter does it in 1. And so you wonder what's being missed by the patient in that translation there. Socioeconomic, they're just the access to healthcare and the infrastructure that poor people have. And now things like skin color and things like that are being sort of taken advantage of in dermatology. People are giving special clinics to people of different colored skin because different medications affect skin differently. And it's nice to see that people are their treatment is being tailored to the race that they're treating. And then aging. So we know the economic impact of disparities is a lot. It's estimated the United States spends about $1.24 trillion. 2.29 billion is direct costs spent on medical care, and trillions in indirect costs. So it's definitely something we need to take advantage of and change because we spend a lot of money on it. Our population is growing and changing. This is a 5-year span, and you look at the Hispanic population, it's increased by 12%. African Americans about 5%, Asians about 13%, Caucasians about 1%. And then you also can see that different groups of people interface with medicine in a different way. And language is a very important interface that we need to conquer and improve. But also some groups are just less trusting of the healthcare system, such as African Americans, because historically, there have been certain things that have happened to African Americans that make us very suspicious of the healthcare system. And it helps contribute to some of the disparities we experience because we don't seek healthcare the way we should. If you look at the people that are in high school, this is old data, but it hasn't changed much. If you look at the people in high school that wanted to be or wanted to talk about being in a position, and look at the numbers for Black, Hispanic, and white. And then you look at the number of people that actually made it to medical school and applied. Blacks went from 18% to 6%, Hispanics went from 24 to 6%, and whites went from 48 to 60. And then look at the number of people that got into medical school. African Americans 6, Hispanic 7, and white was 61. The way I look at this is you don't get these places by yourself. And I say underrepresented minorities they don't have the 4-lane, well-paved highways that the majority of students have. The majority of students have connections, family ties, networking capabilities that underrepresented minorities do not have. And so programs that help recruit these underrepresented minorities, one of the goals is try to help them have a smoother street to get to where they want to be. If you look at minorities that represent about 30% of the population, but look at what percent they represent in the healthcare field. If you look at from the Academy of Science, Engineering, and Medicine, we looked at this looking at vision. And since I'm ophthalmologist, I paid a lot of attention to this. And they were advocating for population health, ensuring eye health. They were looking at avoidable visual loss that affects the underrepresented population more. And they looked at the workforce approach and trying to diversify the workforce because a lot of underrepresented minorities practice in these medically underserved areas. So let's look at African Americans in ophthalmology. So when I went to my residency in the 80s, and I hate to say 80s and it's now 2000, I wish it was 2000, but it was in the 80s. I finished in 1987. We had just under 9 grads per year. And up to now, we're just under 10 grads per year. So over 30 years, we really haven't made much of a dent in ophthalmology. If you look at the census, African Americans are about 13%, but we represent under 3% of ophthalmology. Hispanics, about 4%, Asians 13%. And I congratulate them because they only represent about 5% of the population. And then if you look at the Native Americans, and they represent even a smaller percent. So based on population, we're not even at the percent of the US Census. This graph I put in just to show you where the changes occurred. Over the last sort of 20 years, the changes really occurred from the number of men and the number of women. But if you look at under 10%, where all the underrepresented minorities are, that has not changed much. So what's the problem or the answer to this? One, I think it's the pipeline. I think we need to have recruitment programs in college and high school to encourage students to look into medicine, science, and then for us, ophthalmology. We just celebrated the retirement of one of my counselors in pharmacy school. And this guy, in the retirement, we were on a Zoom meeting for 2 hours, singing his praises. And what I came away with, all of us believed that his success was that he made us believe he believed in us. And this was a white guy who was telling us stories of how he would be driving his Purdue labeled car into the inner cities of Chicago, Gary, and Indianapolis, looking for minority students to come to pharmacy school. And I will tell you, he was a very straight shooter and had very colorful language. And he related to us very well. And he was very successful because on that Zoom meeting, there were a lot of very successful people that went through Purdue Pharmacy School thanks to him. I think we need to tap in more to the underrepresented minority meetings and then undergraduate health symposia. So the National Medical Association and the ophthalmology division has the Rab Venable Scientific Symposium. And this has been a pipeline for students to get into or be exposed to ophthalmology. And also has been a pipeline to some of us who run programs to tap into these young people. And I will say some of these are our future leaders. And one of the ladies on the screen is one of my current residents. So I did use it as a recruiting tool. This young lady here, Bonnie Mason, is an orthopedic surgeon. And I saw her present her organization, the Nth Dimension, was a way to recruit minorities into medicine, but in particular orthopedics. And she started this pipeline. And when I first saw her, I said, we need to do this in ophthalmology. So we convinced the American Academy of Ophthalmology and the Association University of Professors in Ophthalmology to develop a task force to look at this. And what we did, we gathered information about our current status that didn't take a lot of time. And then we estimated the number of underrepresented minorities, and we identified barriers and challenges that contribute to our situation. And one of the things we realized is that in medical school now, primary care is really taking over the curriculum. There was a time when we used to see every medical student in our department, and now we only see the students that like to have a 2-week rotation. So our fear is that because of change in curriculum, and now a lot of students won't even know about ophthalmology. So we thought we should make an effort to not only recruit majority students in ophthalmology, but in particular minority students in ophthalmology. So the task force identified the need to increase the underrepresented medical student exposure to us. What we did, we invited underrepresented medical students to our annual meeting. And it was a 1-day program in Chicago when it first started out. And what we wanted to do was to start the dialogue with students to show them what ophthalmology represented, introduce them to ophthalmologists, and see if we can convince some of them to look at us. We also increased the dialogue with AUPO regarding how do we assess applicants for our residency programs. And we wanted them to have a greater emphasis on holistic attributes. There have been studies that show that test scores and grades really doesn't correlate with how successful a medical student will be in residency. And recommendation letters were significantly stronger. And those are our biases when that people were first author publishers. And then again, our biases come in, and you can read some of the letters. There's been studies show that underrepresented minority letters are just not worded the same as majority students. And so that's something you have to read into and judge for yourself as you recruit these students. And I know in ophthalmology, there are a lot of applicants. We have about 500 applications for 5 spots. And one of the things that we ran into is that a lot of programs use step one scores as sort of a screening number, which oftentimes will hurt applicants. So the mentoring, the task force members and the volunteer physicians connected with these students and served as mentees. And what we wanted the mentees to do is be a personal person to guide these students to research opportunities and how to help strengthen their application. Because without a competitive application, you're not going to get into competitive specialties. So we collaborated with the different groups that are listed here. And it's surprisingly, all of them participated and were very anxious to participate in our programs. But we also found out other specialties are doing similar programs and medical schools are doing similar programs because there's a lot of pressure from deans to increase the diversity of their trainees and their faculty. So our first year was in 2018. We partnered, the partners, as you know, the Academy and AEPO, and our goal was to attract underrepresented minorities to medicine and particularly a career in ophthalmology. And what we wanted to do, most important, was to help students become competitive residency applicants. When I remember when I was applying to medical school, the Bakke case was hot. And Bakke was suing for reverse discrimination in Loma Linda. And almost every place I went to interview, they asked me about the Bakke case. But at that time, the affirmative action programs were trying in an effort to increase minority enrollment. It turns out it wasn't as good of a thing that it was intended to be because you were labeled as only being in an institution because of a program. And that has secondary effects on minority students. And it also had secondary effects on majority students. They were very resentful for these programs. The student demographics in 2018 are listed there. M1 and M2s are really our target group. M3, we feel like are almost too late for us to help. We did have an MD, PhD, and a college senior. You can see the racial mix there. And in 2018, our first year, we had 22 students, okay? We matched them up with a mentor. We provided educational material to them, and then we surveyed them for how well we did. We gave them full access to the Academy's educational material. We helped them with step one exam preparation. It was an 8-month web-based prep course. And then we had a bank of study questions and accessories to help these students prepare for step one, because that was the screening score that they had to pass first. So the feedback was people came in, some were not very interested, some were moderate interested, but when we got done with them, we had 22 students that were very interested. We felt very good for that first engagement. The mentors really worked with the students, but we had speakers to introduce other students and undergraduate college students in ophthalmology, and they were our champions. So champions serve as liaisons for the MOM program at academic institutions. We gave all of them a toolkit. They didn't have to do any work. PowerPoint presentations were done, signage was done. The only thing they do is lend us their voice and food. Some of the highlights, you can see the students were really 15% of them at the end were interested in applying for ophthalmology. We lost a few, lost one to orthopedics and lost one to dermatology. We expected that, but we got 15 of them that thought they would apply to ophthalmology. The most important parts of the program was the student engagement weekend where we were all together. The mentorship relationship was important and networking was important. In 2019, we increased our students to 32 from 23 schools. You can see the breakdown there. The most exciting thing about 2019 was our skill lab. We let them suture on pig eyes. That was the hit of the whole weekend. That's what everybody talked about. But we also offered them tips about applying for residency, interviewing tips, and we gave them more time with their mentors and on our academy floor, and they really appreciated that. And now in 2020, we have 50 students. In the last 2 years, we had over 100 applicants. So this year we increased our numbers to 50 students from 39 schools. You can see the breakdown. Most of our students are M1s and M2s. and we had 2 college seniors. So we've shown continued growth in this program, and hopefully we'll be able to do even more than 50 students, but it does cost a little bit to do that. So outside, we had 184 ophthalmology participants. We have people on different task force. We have people being mentors. We have people speaking at our student engagement weekend. We have presenters on college campuses. And then we have champions in ophthalmology departments, because in 3 years, we've really grown. And there's a lot of interest in this from our national organizations. This slide makes me very proud because all the subspecialty organizations have contributed money to this effort. The American Board of Ophthalmology has contributed, and our oldest society, the American Ophthalmologic Society, has contributed. So that I'm very happy that this is really registered with our subspecialty area, and hopefully we'll continue to be successful and get some of these people into the field. Little video here for you.
So when I first got accepted into medical school, I had someone who I thought was a friend tell me that it was only because I was Black, which was very hurtful because he knew me and he knew what I was capable of.
Our life experiences develop our preconceived notions of different groups of people. And I think that's what we have to work to break down. The Minority Ophthalmology Mentoring Program is a new program sponsored by the American Academy of Ophthalmology and the Association of University Professors in Ophthalmology. Both of those organizations thought it was important to begin recruiting minority students in our profession.
Having the opportunity to kick off this mentoring program at the annual meeting is really very, very important and so helpful. The medical students have the opportunity to see what ophthalmology is all about.
There's not a lot of physicians who are of disadvantaged backgrounds. We should be able to match our patient population and our patient needs. It really makes a difference to our patients to have somebody that can speak their language, and they automatically light up. You can see it in their eyes, and I hope that I'm able to do that as a physician as well.
So when I walked into the room and saw all of the other mentees for the first time, I felt really excited and I felt warm and I felt ready to meet all of them and see what they were about. And I think that that sense of like bristling excitement, I think it's a shared sentiment among all of us.
I think especially this program here today, I think I've seen a lot of people that you typically don't see as a physician, meaning people of color. When you see someone that looks like you, looks different, it's the same feeling that I assume patients get when they see a physician of color that represents what they are.
I think it's very important that the workforce that provides the services to our patient represents the patients that we're serving. I speak Spanish, and sometimes I get patients who come who've been treated for years, and their parents, once I explain to them why it is that we're doing what we're doing for the children, they're like, oh, now I get it. But through an interpreter service on the phone, a lot of it can get lost in translation. I have some amazing physicians, amazing mentors who have supported me all along the way, who support my crazy dreams and aspirations. And I'm hoping that in the future I can be a role model to other students as well.
The experience that this program's offering is very unique. I don't think there's anything out there similar to this. People from all over the country are literally setting up a foundation for you to succeed, and there's nothing like it.
So when I first got accepted into medical school.
Okay, so that's our program in ophthalmology, and I'll be glad to answer questions later on, but I want to switch now to faculty recruitment. All of us are being pressured and encouraged to recruit minorities in our faculty, increase the number of trainees. Almost every institution now has a diversity office, and we need to use them. I think one of the problems with diversity offices is that there's no money behind those offices, and there's not a lot they can do. And I think one thing you can do as a faculty is to encourage your school to support the diversity office. and not just name somebody that a year from now still hasn't been able to do anything because they didn't have the resources. This is really being driven by the attention from the AAMC and the ACGME. And your faculty participation is crucial. And sometimes you may have to have that difficult conversation with your faculty. You're not going to convince everybody that diversifying their department is important, but it is. And you have to work with the people that are willing to listen and help, but don't give up. Involve your minority community. Sitting here in Iowa, I even involve our minority community. What's important is that when you recruit people, they do want to see people that look like them. They don't have to be the majority. They know they're not going to be the majority, but they don't want to be the only one. And I can tell you, bringing people to Iowa, sometimes it's hard to recruit majority people to Iowa. So bringing minorities here requires a little bit extra work. Develop a pipeline. Send your faculty to minority medical meetings. Sell your program, okay? And recruitment doesn't stop with the visit. Please understand that the recruitment doesn't stop with the visit. What you also should do is provide contacts for these people outside the chair of division chief so they can talk and learn about your institution outside the people who are recruiting them. Very important. So if you're successful, now what do? Don't forget your recruit. Provide mentorship. Involve them in departmental activities. And do not load them down with the tax of representing you as a minority every committee to make you feel good. Collegiate committees are good, but be careful, they could be a time sink for junior faculty. Provide a vision for this recruit. Make this recruit feel like this is a department where I can succeed in, and provide equal resources for success. If you do that, you may have them there more than 2 years. If you don't, within 2 years, they'll be gone. And the money, the resources you wasted in recruiting that person will be down the drain. Remember, you just can't recruit the person and bring them to your department and forget them. Include them just like you include everybody else. Include them just like a person you want to be in your department for at least 10 years. I want to thank you for the time for presenting this topic. I think right now is an interesting time in our country, and hopefully these conversations will continue, and hopefully we'll follow up some of these conversations with action. I think what's very encouraging for me when I was looking at the people protesting in the streets, there were a lot of majority of the population, young majority of students in the streets. That's very encouraging. So thank you.
Thank you, Dr. Carter. I want to welcome any questions through the question and answer box, as well as the chat. I'll start off with the first question until we get a question that I see in the box. But Dr. Carter, I was wondering, when you were starting that program, the MOM program, what kind of obstacles did you face in the beginning? A lot of times when you get these programs, I mean, it sounds like by the end you had a lot of the societies within ophthalmology certainly, provide some resource, et cetera. But I wondered what kind of obstacles you had to overcome initially,
I think the first thing was to get buy-in from our national organizations that were providing the resources to get us off the ground. Fortunately, I was president of both of those organizations, so I was able to do a little legwork there. But I will tell you, once the topic was there, once it was laid on the table, once the data was showed, everybody got in line to support it. And people would ask, oh, I never knew. And I tell them, why would you know? It's not affecting you. And so I'm not blaming you for not knowing, but I will like you to support, now that you know, support to make a change. And I think that's very important. I think in this whole conversation, we had to make sure we're not laying blame on somebody. That's not what this is about. This is not about trying to get majority of the population to pay for the sins of history. That's not what this is about. This is about recognizing inequalities and making things better going forward. And if we stick to that and not just point fingers and say who's the bad person, who's the good person, we can make change. But if we go about just blaming people, you just develop more resentment and nothing really changes.
Yeah, that's great. I have a question. Thank you for your talk, Dr. Carter. This is from Sonia Myers. How do you sell diversity to your administration?
Well, I think right now, if your administration is not listening, I think you can go to the person right above your administrator. So if you need to go to the president of the university, this is a topic that's hard for university systems to avoid right now. Students are demanding it. It's amazing the conversations from students to the presidents. I think what's very important though, and you asked a good question, you need to get buy-in from the administration, the leaders of your institution, to actually enact change. What you don't want is a lot of committees talking about it, but none of the leaders are in the committees. And I will say we developed a program here in Iowa, and I'm on it, but also our Vice President for Medical Affairs is on it, and our CEO of the hospital is on it. So those two people control the purse strings at our institution in the healthcare field. So we come up with a change, at least we have the people in the room to control the money to make the change. So I think that's very important. So if you're having a hard time selling this to your administrators right now, it may not ever happen, because I think it's in the news. The ACGME is pushing it. The AAMC is pushing it. So good luck to you. Maybe you should change institution.
Great. Thanks for that answer. There's another question, Harry Gladstein. It sounds that medicine needs to learn from athletic departments with paid recruiters who know how to interview and follow up with candidates, and have department heads to meet with them as well as recruiters. How do you answer? What do you think about that?
I think if I had the end result of multi-million-dollar contracts, maybe it'd help with that. But there's something to the correlation between athletics and what we're doing. The only difference is I hope we're not using the athletes like athletic departments are using them. I want to educate people. I want to give them a better life. And as we know, if you don't make it in athletics, a lot of times these kids don't benefit from higher education. And I wish we did a better job of that. But I think if you had good recruiters, like I had a good recruiter in pharmacy school, we recruited a lot of star players, only because he saw some talent in us that we didn't see in ourselves. If you have those working for your organization, you'll do well.
I'm going to let, I think Dr. Gladstein speak. Actually, may want to follow up on that. So can we unmute him? I don't know if I can do that, or Samira.
He's unmuted now.
Okay. Did you want to speak, Dr. Gladstein? No, maybe not. There was, if we'll wait. If you want to, we can unmute you again. I think there's another question from Dr. Robert Hosang. Is there a part of the country here where there are greater opportunities for making progress at the undergraduate level? Maybe
parts of the country?
Yeah, let me see. Dr. Hosang, do you want to unmute yourself? This is what I'm just reading the question, and maybe I don't understand it well enough. Can we unmute Dr. Hosang?
Hello.
Great.
Yeah, so I was just asking if there was a part of the country, or if there are parts of the country where there are greater opportunities to do that undergraduate outreach, so that the effort can actually be more productive.
Well, I think these outreach efforts are occurring at a lot of institutions. I mean, I can tell you here at Iowa, we go down to a lot of the southern schools and recruit students up for summer programs to expose them to the University of Iowa. I think you have to go where the students are. And I think a lot of schools are doing that. I think what happens a lot of times is there's not a lot of follow through. And I also think historically, there's been debate on where the effort should be. So should it be socioeconomic or should it be talent? And I remember long ago here at my institution, it was socioeconomic. It was in there disadvantaged. And I remember suggesting a student be put forth for a mission. And the voice came out that she was not disadvantaged because her mother was a nurse and her father was an engineer. And so my response to that is that you just told me my kids can't go to medical school at Iowa because they're not going to be disadvantaged. And I said, as well-meaning as that was 10 years ago, I think we need to change it. And there's still debate about that, is who should the programs be targeting? And my goal is target people that can succeed. I'm not interested in 15 students being admitted and only 3 graduate. I want 10 people admitted and 10 graduate. So you do whatever you need to do that. I don't want a number to make the institution look good.
Right. Great point.
I hope that answers your question.
Yes.
Okay.
I think we have Dr. Pham. Dr. Pham, I will unmute you. I think you have a question. Why don't you go ahead and answer it live, if you can. There you go.
Thank you, Cliff. My question is, as somebody who sits on the other side of the interview table, how do you get past the Bucky case in admitting students who don't score high on the MCAT, or admitting residents who don't score high on the USLME Step 1?
Well, I think, and I'm not naive, and I know programs are screening. When you have 500 applications in ophthalmology looking for 5 spots, they are screening using these scores. I know that. And so that's very important that these students are competitive to get through the door. I can also tell you that, people call, you have alums that call about a student is applying, they tell you how great they are, and you look and see that they didn't make the first cut. And so you go back and give a person another look. And some of those people have been some of the best residents we've had. In selecting residents, is nothing objective about it. It's a lot of subjectivity to it. And so a score is one thing, but it doesn't mean that's going to be your best resident. And I think you have to take into other accounts. You have to look at the whole picture and not just look at scores. I think studies have shown that scores by themselves look nice and make us feel good. We use them as screens, but it doesn't necessarily say you're going to have a great resident. And so what I would recommend, Randall, is that people look, you can include scores. I'm not saying you take unqualified people, but look at their grades in school. Look at years of grades versus one day of a test, and see if that shows you may have a competitive person that just didn't have a great day on that standardized test.
My second question is, given the fact that USLME score is not everything, how do you, can you have any correlation between passing the ABO, American Board of Ophthalmology exam? Is there any correlation with passing the board with scoring high on the USLME Step 1?
No, there's not been a correlation there. And there is some correlation doing well on OCAPs, but the training you have to have and the practice of taking these tests, I think, can overcome any deficiencies you have in taking a test. And the good thing about the boards, you also have an oral exam, so you have an opportunity to explain yourself orally also. So I think in preparation, if you go to ophthalmology training program, that most of the people that graduate pass the boards. So I think the training is good, and I think that we groom people to take that test. And I don't think there has a lot of correlation with Step 1 or 2 of the boards.
Well, thank you so much. My last question is, you mentioned that it would take very long for society to change, but within organization like the American Academy of Ophthalmology, how soon you think that we can make a difference? I saw that you had a remarkable result with going from 20 to 50 members of the applicant group from involvement with the AAO, but can you give a timeline? You go from 20 to 50, maybe in 5 years you can go to 500.
Well, that would be great. We have over 100 to 120 applicants a year, and we were able to increase our numbers this year for a variety of reasons. One, COVID saved us money on travel, and so we spent the money on students. And we are doing better in fundraising for the program. We're trying to make the program a little bit more self-sufficient and not supported just by the organizations. But the memberships the membership of these organizations are very supportive. So I think as our finances get better, we'll be able to expand the number of students. In 5 years, we hope to give a progress report on how many students we touched and how many people matched in ophthalmology. That's going to be the rubber on the road. That's going to tell us whether this program's been successful. Just having students, like I said, just having students come through, if they don't go in ophthalmology and they don't match in ophthalmology, then the program didn't do what we intended to do. So in 5 to 6 years, we'll have more information. We'll tell you how successful it is.
Thank you, Dr. Pham. We have a special guest now. Dr. Miner is the Dean of the Stanford School of Medicine. I don't know if you'd like to say anything, Dr. Miner, if you wanted to unmute yourself. This is a really important topic, and I think can't see if he can we unmute him? Can I unmute him? There we go. Dr. Miner, I think you're unmuted now.
Hello. Well, thank you very much. I thought that was a wonderful presentation and of such an incredibly important topic. And I think all of us have so much to do, so much that we need to accomplish. And I want to thank the organizers for presenting this today and for giving all of us an opportunity to learn from the discussion. So thank you.
Are you doing anything at Stanford in particular, Dr. Miner, around these issues in terms of recruiting faculty and anything that you or students, I would say as well? So,
well, absolutely. So the class that we just enrolled, that just started about 4 weeks ago, is the most diverse class in our history. So about 34% of the students are from groups underrepresented in medicine. 22% of the incoming students are Black, and large representation also from the LGBTQ+ community. My colleagues and I, Paul King, the president CEO of Lucille Packard Children's Hospital, and David Entwistle, the president CEO of Stanford Healthcare, have established a commission on justice and equity that includes leaders from around the country who have special expertise and areas of focus in this important discipline and these important topics, as well as internal leaders within Stanford. And the goal is to get outside perspectives on what we're doing here now in all areas of diversity, equity, and inclusion, and to also really help us as we aspire to be a leader. We certainly want internally to improve our performance in diversity, equity, inclusion. In so doing, we want to be a leader, to be able to show the way for other institutions and to model programs and behavior that others can learn from as well. And I want to really thank Dr. Carter for a very engaging presentation and for the great work, Dr. Carter, that you're doing in your home field of ophthalmology, and also what you're doing at the University of Iowa and more broadly, academic medical centers across the country.
Dr. Miner, I would tell you, I congratulate you on your efforts, because when we look at different institutions and medical centers and healthcare centers, Stanford is doing very well in the area of diversity. So keep up the good work. We hope to mirror you.
Thank you.
Thank you. Thank you, Dr. Miner. I have another question from, I think, Dr. Goldberg, which is a tough one for, is it possible that highly paid specialties may siphon off URM from the primary care specialties. With limited healthcare access and great disparities in health outcomes, don't minorities need many more primary care docs, even more than specialists?
That's a
Tough one.
great question.
Mm-hmm.
That's a great question. What I would say, let's recruit enough that we can serve both.
Yeah. That's true.
Right now, there's a big push for underrepresented students to go into primary care. There's no doubt about that.
Yeah.
All the subspecialties are fighting, trying to show them there's other paths in medicine and just spread the wealth. The problem is our pipeline is small. And that's why these efforts to recruit more students into medicine and show them the different subspecialties, they're being shown primary care. I can tell you that. But it's a good point. If you recruit them away, you're spreading a thin team even thinner. But I don't think it's right for us to ignore the fact that we're very underrepresented in the subspecialty areas.
Great. I mean, no, I agree with that. I think that, they're both needed, and there's some areas that are very, very underrepresented in some of the subspecialties and stuff. So I think there two people might want to unmute, Carol Summersill and Eric Sibley. Dr. Sibley, would you like to unmute them? And I think they had a question.
Hello, am I unmuted?
Yes.
Oh, wonderful. I want to just say that this talk has just been amazing. My husband and I have been working toward diversity inclusion efforts in the Bay Area since we moved here. And I'm a private practitioner who is working on similar programs in my hospital. And my husband was the first African-American to rise through the ranks to full tenure professor, and is really working to try to get more minorities in levels of leadership within these institutions and hospitals so that we can really see our own and build up our own. Thank you.
Great.
Thank you.
And did your husband want to speak, Carol, Eric Sibley? I'm not sure. Or I don't know if he's on or not. If not, okay, let me just look down here.
No, thank you.
Okay, thank you for those comments. Just checking the time. I mean, one of the questions you mentioned, Dr. Carter, is kind of looking at the pipeline, and I know we talked about medical students, but how about even sooner than that in the high schools and, even at grade school? Because it seems like, this interest in science and medicine, it's something that you want to start and cultivate early, but I don't know if you know of efforts around that to help, early on, even earlier than even college. But college is also a good start.
No, you make a great point, and that's where we have to start. For us, we had to start where we can have an impact, and that was in medical school.
Yeah.
We do touch undergraduates a little bit, but again, we need more of them in the pipeline coming from high schools. And there's a lot of programs trying to motivate women and minorities to get interested in science, the sciences, engineering, et cetera. But again, we're going to be competing for all these folks. I mean, there's a gender equity. We're going to be competing with all these women. I mean, it's good, but we need more people in the pipeline to satisfy what we were trying to recruit to do. Yeah. If not, we'll be in the same boat 30 years from now.
Yeah.
And we'll be saying what happened. I don't think we will be, because there's a lot of emphasis on it. I know women are going to be much better off 30 years from now than they are now.
Yeah.
I hope minorities can follow suit.
Yeah. I mean, one thing I thought that was really interesting in your program is that you did put resources behind it. So there were things around, helping them with their step one and getting their resume together and things like that. I think, that takes time and effort as well as, money and stuff. And that's a part that often gets left out, is that you don't have the resources. You have the interest, but, you don't, it's, well, there's, it's like we always say, when there's no margin, there's no mission. And so right. The same sort of thing. And how have you been able to garner those resources? I think, just a question from my standpoint, because that's always something that whether it's time or money.
Well, time, we were very surprised. There were a lot of ophthalmologists and willing to donate time.
Good.
Our national organization started with a big give. So then we were able to go to the subspecialty organization, and now we're going to industry this year. This is the first year we're actually going to industry.
Great.
The other thing we're doing is really educating our mentors better. So they can better, one thing people will think, oh, I'll be glad to talk to the student. But we need more than that. We need people to be champions for these students and to help them navigate these competitive residency applications and know what they need to do. We have a bank of research opportunities across the country for them to tap into. We are talking to mentors about short-term projects that they can publish something. Trying to check off the boxes that you can get attention to the selection committees. This year we're forming mentor teams. So you may have a primary mentor, but you may have a scientist that's willing to help a student, but they don't have a lot of time to take them through all 2 or 3 years, but they can use them as they want. So as we're growing, we're trying to improve our mentorship program to help these students. And that's coming from the feedback from the students as we do our surveys.
Great. I think one more question from Dr. Sibley. Can't medical schools open up more spots for students?
Now we're back to resources. I think you had to realize a lot of money comes from the government.
Yeah.
The government tried that back in the 70s, trying to oversupply the system with doctors, and it backfired. I think there are some new schools opening up. I also think that's a loaded question because it depends on where medicine goes in the future. Yeah. What's going to be the future of subspecialties? What's going to be the future of primary care? How will our healthcare be delivered? Just having more doctors, the way things are now, you may just have more subspecialties that are driving up the cost of medicine. So that's what happened. Doctors, these are smart people, and they adjust to the marketplace. Even though we are trying to take care of our patients, at the end, we have to pay off the debts of medical schools, so we have to make a living also. So sometimes choices are made driven by the dollar, even though we don't want to admit that. The only thing you have to do is look at a specialty that's been hit financially and then go to graduation. You'll see they're not going into that specialty. It's really amazing. I have to go to graduation every year. That's what I look at. I say, okay, who got hit this year? And you just remember a student going to that fell.
That's right. That's great. I'm going to ask if there's any last questions. Anyone want to just let me know and we can unmute you, or if you want to put a question in the chat, the question in A section. I'm just checking. Don't see anything else. All right. I think. Okay. Well, that was a fantastic talk, Dr. Carter. Thank you for answering all those questions. Let's not stop here, as we say, and continue the work, the good work, I think, and we really do want to address this issue from a nationwide standpoint, but locally within our own Bay Area as well. So I want to thank all of you for attending. Just want to remind you that our survey will be emailed to you shortly, and you'll receive their CME certificate upon submission of the survey and a certificate of attendance. If you have any questions, email Samira at sccma.org. And I also want to thank you for all the Bay Area Medical Societies for collaborating and creating this diversity series. I want to invite the audience to our 4th session, which will be on health equity, resilience, and leadership in a time of crisis with Dr. Rhea Boyd. So I want to thank you, Dr. Carter, for the wonderful presentation and all the work that you are doing. It's fantastic that you've really mentored so many new students and residents and faculty into the field of ophthalmology, where it's really greatly needed. So thank you all for participating and for all who attended, and have a good night.
Thank you, Cliff. It's my pleasure.
Thank you. I think we're